Pharmacology nursing students, let's talk labor and delivery med. Whether you're preparing for an exam or heading into clinicals, knowing how these medications work can make all the difference in patient care. Let's break down 5 common medications that you will see on the labor and delivery floor. Let's talk about Pitocin, Terbutaline, Magnesium Sulfate, Misoprostol, and Dinoprostone. Our first one, Pitocin. This is the contraction starter. This is a synthetic oxytocin that stimulates uterine smooth muscle contractions. It does this by increasing intracellular calcium levels. We can use this medication for a variety of things, including induction, augmentation of labor, and postpartum hemorrhage prevention. Side effects include tachysystole, which is an excess of contractions, and water intoxication. Pitocin actually has a similar chemical structure to antidiuretic hormone, so due to this, it has ADH-like effects. It can also cause fetal distress from decreased oxygenation. Some of the nursing considerations you want to keep in mind is that you need to be doing continuous fetal monitoring. The hyperstimulation of the uterus can potentially cause fetal hypoxia. You want to titrate this medication slowly, start low and go slow. Assess for water intoxication. Those symptoms can be headache, confusion, and decreased urine output. Let's do a quick knowledge check. Why do we worry about tachysystole? Well, too many contractions means less time for placental perfusion, which means fetal distress. It can also mean exhaustion of the uterus and increased risk for hemorrhage. Our second medication is Terbutaline, which is the contraction stopper. This medication is a beta-2 agonist that relaxes uterine smooth muscle by increasing cyclic AMP. Overall, what this does is it inhibits that contraction signal. We use this for preterm labor, essentially to delay labor, or if we have induced labor and we have uterine hyperstimulation, we can slow it down. Side effects include maternal tachycardia, palpitations, hypotension, hyperglycemia, and pulmonary edema. Remember, this drug interacts with beta-1 receptors. Our nursing considerations to keep in mind for this drug is hold the medication if the heart rate is above 120 beats per minute. Tachycardia is a common side effect. So if their heart rate is already too high, that's something we want to be aware of. Monitor for blood sugar. This can cause hyperglycemia by increasing that glycogen breakdown. Assess lung sounds. Watch for fluid overload, pulmonary edema. Our third medication is magnesium sulfate. This is the neuroprotector and tocolytic. This medication works as a calcium antagonist, so it's going to relax uterine muscles and stabilize the nervous system by blocking that neuromuscular transmission. We can use this for preterm labor, seizure prevention, and preeclampsia. Our side effects that we need to know are respiratory depression, hypotension, diminished deep tendon reflexes or DTRs, flushing, and lethargy. Our nursing considerations you want to keep in mind is monitor for toxicity. Signs of this are going to be absent DTRs, respiratory depression, and a decreased urine output less than 30 mLs an hour. We have an antidote for this medication. It's called calcium gluconate. And you want to keep in mind to do fetal monitoring. This can cause newborn flaccidity and respiratory depression after delivery. Quick knowledge check here. Why does magnesium sulfate prevent seizures in preeclampsia? Well, it's going to reduce CNS excitability, preventing hyperreflexia and overall seizures. Our fourth medication is Misoprostol. This is our cervical ripener. This acts as a prostaglandin E1 analog that softens or ripens the cervix by stimulating collagen breakdown and induces uterine contraction. We can use this for cervical ripening for labor induction and postpartum hemorrhage management. And it's also used in pregnancy termination. Our side effects for this are going to be uterine tachysystole, fever, and diarrhea. Nursing considerations to keep in mind, it is contraindicated in a previous C-section for risk of uterine rupture. Monitor for hyperstimulation, which is the risk of tachysystole and fetal distress, and it can be administered in a couple different ways. It can go vaginally, orally, and rectally for postpartum hemorrhages. Quick knowledge check here. Why does misoprostol cause diarrhea? Well, it's a prostaglandin, which also stimulates the GI tract, which increases motility. Our fifth and final medication is Dinoprostone. This medication is like a cervical gel. It is a prostaglandin E2 analog that softens the cervix by breaking down collagen and promotes uterine contraction. We use this for cervical ripening before labor induction. Some of the side effects you might see with this is uterine hyperstimulation, nausea, vomiting, fever, and fetal distress. Keep in mind that patients need to remain supine for 30 to 60 minutes after insertion to allow for absorption. Remove the insert if tachysystole or fetal distress occurs. And we want to use cautiously in patients with asthma as it can cause bronchoconstriction. Quick knowledge check. Why do we remove Dinoprostone if tachysystole occurs? Well, unlike misoprostol, Dinoprostone is a vaginal insert, so removing it can actually stop that drug absorption. A quick recap. Well, Pitocin induces labor, but we need to watch for hyperstimulation and water intoxication. Terbutaline stops contractions, but can cause maternal tachycardia. Magnesium sulfate prevents preterm labor and seizures, but can cause respiratory depression. Misoprostol will ripen the cervix, but it can cause uterine rupture in VBAC patients. And Dinoprostone is another cervical ripener that requires removal if hyperstimulation occurs. If this was helpful, don't forget to save and follow along for more Pharm for Nurses.